Hi, everyone. Thank you for joining me for the GAP MASLD MASH Community Network. Today, we'll be talking about comparing F3 and F4 fibrosis. We'll talk about two patient cases that will be the same patient with same background with two different non-invasive testing scores that come back. My name is Punam Punja. I'm a PA at Emory Healthcare in Atlanta, Georgia. Please use this QR code to register for the meeting. And we'll start off by talking about case A, which is Sam. He's a 55-year-old Caucasian male that was referred to you because he had mildly abnormal liver enzymes. He also had an abdominal ultrasound that showed increased liver echogenicity, suggesting hepatic steatosis. He also complains of fatigue. And when you look at his past medical history, he has all the metabolic risk factors, a BMI of 33, type 2 diabetes, hypertension, hyperlipidemia, which he's taking medications for. He also has sleep apnea, denies any alcohol use, and on physical exam, he has an obese abdomen and no stigmata of advanced liver disease. These are signs of jaundice or ascites that are not noted. So when looking at his labs and vital signs, his blood pressure was a little bit up coming into the office, but his ALT and AST are both elevated. Normal liver enzymes for a male are usually 35 and below. His alkaline phosphatase is around 120. Depending on which lab you use, sometimes this level could also be abnormal. His total bilirubin is normal. Platelet counts are normal. Hemoglobin A1C is elevated at 7.1%. Creatinine, INR are also normal. Ferritin's elevated, but iron saturation is normal at 30%. Ferritin can be elevated in patients that have steatotic liver disease. The ANA also came back weakly positive, and I would recommend completing immunoglobulin tests to look for any signs of autoimmune hepatitis or underlying autoimmune hepatitis. Approximately 23% of patients with steatotic liver disease can have falsely positive ANA levels. The ASMA was negative, Hep C antibody was negative, Hep B surface antigen was negative, and the Hep B surface antibody was also negative. I would also check an AMA to ensure that that comes back negative. I would recommend a Hep B vaccine in this patient, and I would also check a hepatitis A status just to be sure that he is immune to hepatitis A or needs a vaccine for Hep A. Because he also complained of fatigue, I would also recommend checking a TSH level as well. So when you look at his fibrosis assessment, his FIB-4 score, which includes a patient's age, platelet count, AST, and ALT, came back at 2.74. This is an indeterminate risk of whether or not he has advanced fibrosis. His FibroScan came back at 11 kilopascal, suggesting that this patient may have significant fibrosis or F3 fibrosis. His CAP score was around 262, consistent with moderate steatosis, and his ELF test came back at 9.9, which is suggesting severe fibrosis. So is there any further testing you'd like to perform on this patient? As I mentioned earlier, I would check immunoglobulin testing to make sure that that comes back negative. If it comes back abnormal, I would recommend having a liver biopsy done. Check his hepatitis A status, recommend a Hep B vaccine, check TSH just to make sure that the fatigue isn't from that. But a lot of patients that have steatotic liver disease also have symptoms of fatigue. Check an AMA, and if you have access to an MRI with elastography, I would also recommend that because that will help confirm that this patient has F3 fibrosis. I would stage this patient as F3 based on the FibroScan test as well as the ELF test that was done. So how would I treat this patient and monitor this patient? Because this patient has F3 fibrosis, he is a candidate for MASH medications. This includes Resmetirom, along with GLP-1 that can help with the underlying steatosis along with fibrosis and inflammation. I would also recommend exercising, at least 150 minutes of exercise per week. Recommend a Mediterranean diet. Recommend anywhere from 5 to 10% weight loss to help with the underlying steatotic liver disease. Also recommend a multidisciplinary approach. Have the patient see cardiology, endocrinology, possibly a dietitian, and then monitor for HCC in patients that have F3 because there's a small percentage of patients that don't have cirrhosis but are at risk of getting HCC. So you want to have this patient undergo an ultrasound and an AFP possibly in 6 months. So now imagine we have the same patient, but with different labs. So same past medical history, same physical exam, same list of medications, but now his platelet count is lower at 128,000. His total bilirubin is also a little bit higher at 1.4, along with the creatinine level. All the rest of the labs come back the same. I would still recommend the same thing in this patient, checking the AMA, the Hep B vaccine recommendation, along with the Hep A, and so on. But now his non-invasive test scores have come back different. His FIB4 came back at 3.36, suggesting this patient is at high risk of having advanced fibrosis. His FibroScan came back at 21 kilopascal, suggesting this patient may have cirrhosis. His CAP score was a little bit lower at 245, but in patients that have cirrhosis, the CAP values are often lower because cirrhotic livers typically have less steatosis, and the altered tissue architecture impairs the CAP's ability to detect fat accurately. His ELF score also came back elevated at 0.4, suggesting that the patient has cirrhosis. So is there any other further testing you'd like to perform? I would consider an MRI elastography if you have access to this, or a liver biopsy if further staging is needed. I would stage this patient as having cirrhosis based on his FibroScan results as well as the ELF test. And so how would you treat this patient and how would you monitor the patient? So currently, there are no approved MASH medications for patients with cirrhosis. You want to treat the metabolic risk factors, recommend diet and exercise, lifestyle modification, monitor for hepatocellular carcinoma every 6 months with an ultrasound and AFP, screen for esophageal varices. Once again, recommend a multidisciplinary approach, have the patient see endocrinology to try to get the hemoglobin A1C less than 7%, recommend a dietitian consult, and you want to monitor this patient every 6 months. So looking at patient profile A and B, as you see, the FIB4 score is 2.74 for the patient that had F3 underlying fibrosis versus 3.36 for the patient that has cirrhosis. The ELF score also different at 9.9 versus 11.4, and the transient elastography, the kilopascal at 11 versus 21 kilopascal. So how do these two patients compare in management? Overall, they have similar management recommendations for lifestyle modification, but with the patients that have F3 fibrosis, they are candidates for therapy for their MASH with F3 versus once you get to F4, which is cirrhosis, unfortunately, there's no approved therapies at this time. And which non-invasive test do you most typically use to differentiate between F3 and F4? As I mentioned earlier, if you do have access to an MRI elastography, that will help differentiate between the two. Anytime that there's indeterminate non-invasive testing, a liver biopsy is always an option. And when is HCC surveillance important? The higher the fibrosis score for a patient, the increased risk of HCC there is for that patient. So as I mentioned earlier, there's a small risk of HCC in patients that do not have cirrhosis. So it's also important to screen these patients, especially if they have liver enzymes that go up, an AFP level that goes up, or any other symptoms that may occur. For more disease state education, please visit the GAP MASLD MASH Community Network for additional disease state education and Resdifra webcast. We'd appreciate any of your feedback by scanning this QR code. And if you have any questions, please let me know. Thank you.